because I'm going to from current practice in UK management of children with asthma. So that's my historical slide. I can't compete with Ian's slide, but we've had UK preventable asthma deaths for many years in the UK, and there's been no change for the last 50 years. And we can't really carry on doing exactly the same thing over and over again and expecting different results. Will spoke about the National Review of Asthma Deaths. I'm not going to spend too much time on this, but just to remind you, this was a confidential inquiry delving into the deaths in the UK between 1st of February 2012 and subsequent 12 months. We looked at all death certificates with the word asthma. There were 3,500 of those, and there were 1,400 patients classified as having died from asthma that year, of whom we analyzed 276 sets of notes, having excluded 40% because they were not asthma deaths, or there was no evidence that the patients had asthma at all. And the conclusion in these 276 cases by the panels of colleagues like you and me with an interest in asthma was that there were major preventable factors in over 65% of that 2/3 of that population who were actually classified by the panels as having asthma deaths. There was major failure to recognize risk, in particular past attacks, and control has been spoken about quite a bit today. And I'd just like to emphasize that asking the ACT questions or the 3 RCP questions is not enough when assessing control. Previous risk factors like past attacks need to be taken into account as well, rather than the snapshot during a single consultation once every 6 months or once a year. There was a clear failure to educate patients, with just under half of those people who died not having sought medical care or achieved or accessed medical care during their final fatal attack. Not surprisingly, 3/4 of those people had no records in their records of having been provided with a personal action plan. I'll talk about mild asthma and severity in a little while. And 2 key findings, which are well known by now, but not acted on very well, is that in the UK, we're prescribing excess short-acting beta agonists for people with asthma, and we're not prescribing sufficient inhaled corticosteroids. For some reason, my watch has stopped. Okay, so this was the data for the patients in the National Review of Asthma Deaths. And you'll see that of the 28 children for whom we had records, only one was managed according to good practice in the opinion of the panel members. 42% of those children who died were thought to have mild or moderate asthma, and I'll come back to that. Will already showed this data from the Nuffield study, where asthma deaths in the UK in the 10 to 24-year-olds is the highest in the world. And it hasn't changed. We haven't improved. Now, just to talk about guidelines, in the UK, we have 2 sets of guidelines, quite a bit of conflict between the 2. And we have the GINA strategy documents. And I would urge you to have a look at the GINA documents. The website address is shown on the screen. And GINA, for those who aren't familiar with GINA, was established by the WHO in 1993. And it's not a guideline, but it's an integrated global evidence-based strategy document intended to be adapted for local health systems and availability in different countries. Now, a key difference with between GINA and the guideline documents I showed you is that the questions we address are not limited to individual PICO questions. Since 2014, the GINA report has included multiple practical resources and charts intended for generalists, and about 500,000 copies of the GINA resources are downloaded every year. And GINA is updated annually following a twice-yearly cumulative review of asthma literature. Other guideline updates differ. I mean, BTS sign was updated in 2016 and then 2019. ERS ATS severe guideline was updated in 2020, 6 years after it was first written. And in the US, their guidelines were published in 2007. We're expecting an update this year, but don't hold your breath. One of the advantages of updating guidelines annually is that you pick up on important research information. And in this case, I've shown the slide on the FDA boxed warning about serious mental health side effects for asthma and allergy due to Montelukast treatment. So it is important to have guidelines updated regularly. So the key changes in GINA 2019 were twofold. The fundamental change, after 50 years of advocating short-acting beta agonists as first-line treatment for asthma, we have recommended that treatment of asthma with short-acting bronchodilators alone is no longer recommended for adults and adolescents. And this is a population-level risk strategy, similar to that for antihypertensives and statins. And while individual patients may not benefit, the population may benefit from this. Now, just to talk a little bit about mild asthma and to dispel the myth that mild asthma is not dangerous. This was a study published in 2007 where the authors looked at just under 100 papers where mild asthma was the subject. And these were patients who had symptoms less than weekly in the previous 3 months. 30 to 37% of adults with acute asthma had bad attacks. 16% of patients, this is including children, had near fatal asthma attacks. 15 to 20% of adults died from asthma. Now, there aren't many studies on children, but there are 2 studies from Australia, which I'm going to show, which were included in that DUSA study, just to illustrate that mild asthma, defined as infrequent episodic asthma, i.e. less than 2 attacks in the previous 6 months with symptoms less often than monthly. So infrequent episodic asthma affected 42% of these patients studied in this particular research project. 66% of those children had no inhaled steroid prescriptions. And in those with more severe asthma, you can see that 30% and 17% had no inhaled corticosteroids. Clearly modifiable risk factors which should be dealt with. Similarly, another Australian study on 141 children and young people, half of them who were admitted to ICU and half of them in general wards who acted as controls. And I just wanted to point out that a high proportion of patients present with the first ever episode of asthma and end up in ICU, 10% in this case. And of those with mild asthma, i.e. infrequent episodic asthma, 29% ended up in ICU and 45% were treated in the general wards. So just to drive home the point that mild asthma does not mean don't worry. All patients with asthma are at risk or potentially at risk, and they should all be afforded good quality treatment. So the background changes to the background to those changes in 2019 were, first of all, data that regular or frequent use of SABA is associated with adverse events, including beta receptor downregulation. So the drug doesn't work in people who get the drug frequently. Decreased bronchoprotection, and in fact, rebound hyperresponsiveness and bronchospasm. And high use of SABA has been shown to be associated with adverse clinical outcomes. There's quite a few papers demonstrating that patients who prescribe more than 3 canisters of salbutamol a year is associated with higher emergency department presentations. One of those studies from Shauna McKibben and her group at Barts, published in the Primary Care Respiratory Journal, and another study published a few weeks ago in the Sabina series, the UK Sabina paper, emphasize that point. And we've known for many years that dispensing more than 12 canisters of salbutamol a year is associated with high risk of death, which we showed in the NRAD report. So in addition to the SABA recommendation, GINA now also recommends that all adults and adolescents with asthma should be treated with ICS containing controller treatment, either as needed or regularly. And this is to reduce the risk of serious exacerbations. So we've got two choices, either regular low-dose inhaled corticosteroids with as-needed SABA, and there's a large body of evidence to support that approach, or as-needed low-dose inhaled corticosteroids with formoterol, long-acting, rapid-acting, long-acting bronchodilator. Now, the evidence for this approach is all with budesonide formoterol at the moment. And initially, there were the two Sigma studies, which were published before we made this recommendation. And in one of them showed a 64% reduction in severe exacerbations versus SABA PRN. Now, there were two additional studies which were published subsequently and included in our 2020 update. And these were the novel START and the practical studies, which showed a severe reduction in severe exacerbations in patients using as-needed low-dose budesonide formoterol in an open-label study, i.e. real-life study. So we showed that this approach does help, it's effective, and it utilizes a lower average dose of ICS in these patients. Now, both studies included inflammatory markers, and I would like to point out that reduction in risk of severe exacerbations with as-needed ICS formoterol was independent of the baseline characteristics, including blood eosinophils and exhaled nitric oxide. These studies have included nearly 10,000 patients to date, and an additional RCT of taking ICS whenever SABA is taken in children aged 6 to 17 years of age provides further evidence that adding ICS to as-needed SABA in children aged 6 to 11, which is one of our newer recommendations, is justified. This is the figure that's used most widely and downloaded most widely. And I'm showing it not only to point out our preferred controller options in mild and moderate asthma, but also to emphasize that asthma treatment is not just drug treatment. It also involves assessment, adjusting, reviewing response. And the new feature that we added on includes patient preferences and goals in assessing these patients. So it's not just drug treatment. That's the chart for the adults and adolescents over 12. And in children, our chart emphasizes the optional controller option to add ICS whenever SABA is taken. Again, with the aim of reducing risk, reducing severe attacks, and keeping patients safe. We've added a couple of new charts this year to help clinicians who are not so experienced to initiate treatment, to identify at what point they should initiate treatment. Because of course, you shouldn't be starting treatment at step one and gradually escalating it. You start at the most appropriate point in the, according to the current symptoms that the patient is suffering from. Now, a bit of medical legal stuff. I've been involved in inquests, and I don't want to sit behind crying parents anymore. It is terrible to sit through a case where parents realize that their child might not have died from asthma had their child been treated differently. Now, the principle underlying most medical legal cases is this Bolam principle. It sets out that a doctor is not negligent if the doctor has acted in accordance with a responsible body of opinion. Now, I'm sure most people, and certainly the courts and the inquest courts, accept that guidelines and guidance documents constitute the opinions of a responsible body, and that these can be relied upon and in most cases have a logical basis. I emphasize the logical basis because that's where some dissension does occur in these cases. So where a doctor deviates from guidelines is where problems arise. And if a doctor deviates from guidelines or guidance or established research findings, is there a responsible, reasonable body of medical opinion which would support this? And where a doctor has deviated, are these reasons recorded in the records? Now, the Belitho amendment to Bolam by the House of Lords was that if the court must, in addition to Bolam, the court must also be satisfied that a body of opinion has that is being relied on has a logical basis. So let's just look at the salbutamol weaning plans in place in the United Kingdom. And this is a UK phenomenon. Salbutamol licensed dose, apart from emergency use, is 1 or 2 puffs PRN 4 hourly. Now, by prescribing 10 puffs 4 hourly for 5 days, we remove a danger signal. We teach our patients that the need for reliever salbutamol is a signal that their asthma is going out of control. So we remove that early warning symptom for patients if they're after being discharged from hospital. It's very difficult for clinicians to determine if an attack has resolved if a patient is taking these astronomical doses of a reliever bronchodilator. And unfortunately, patients learn this behavior, and I've seen examples of this where patients delay seeking help because they've been puffing 10 puffs every 4 hours. There's evidence of risk in adults that B2 receptors response diminishes to salbutamol if it's used regularly, and I'm sure I've got no reason to doubt that this would be the case in children. Now, the Asthma UK Personal Action Plan states, if 10 puffs of salbutamol is needed, seek urgent medical help. Now, if they're taking 10 puffs every 4 hours, we're really negating the advice that we're given in the personal plan. And there's also evidence that regular use of salbutamol can cause bronchospasm. So is this weaning plan based on a responsible body of opinion and has got a logical basis? In my view, no. This management is neither in accordance with a responsible body of opinion, nor has it a logical basis. Now, I mentioned that Bolam was extended to include the logical basis. And sometimes if a doctor can show that their action, which deviated from a guideline document, has a logical basis, they will not be found negligent. Now, just a couple of other points to raise. Oral corticosteroids. The British guideline says treatment for up to 3 days in children is usually sufficient, but the length of the course should be tailored to the number of days necessary to bring about recovery. Next time you prescribe 3 days of oral corticosteroids without arranging follow-up with somebody trained in asthma, remember what I've said today. A lot of attacks take 10 days to resolve, even longer. So just prescribing 3 days is not logical in many cases, certainly without a review. Similarly, the British guideline says we should be using objective tests to assess acute asthma attacks. And in the inquest cases I've looked at, peak flow rates, respiratory rate, heart rate, hardly ever measured. The doctors rely on whether a patient can talk in sentences. And for those in doubt, I know Jen will probably talk about Tamara Mills, who died just before her 14th birthday after 47 attacks in her last 4 years of life. Produced a perfect spirometry tracing, despite having 40% predicted FEV1. And this was in casualty 2 nights before she died from her asthma. So do the lung function if you can, it is useful. So think for yourself, don't just follow the herd unless you're sure that they are right. So Gina recommends for safety, SABA-only treatment should no longer be used in step 1. All adults and adolescents should be treated with inhaled corticosteroids. Children under 6 to 11 should get ICS whenever they use salbutamol, and practice safely in accordance with a responsible body of opinion. Thank you for your attention.
Dr. Levy, thank you so much for such an interesting and kind of insightful call to arms, I think, about changing our practice. I just wondered, you spoke a little bit about the fact that the UK discharge plan for acute asthma attacks doesn't seem to make much sense. Do you have any examples of worldwide practice that you feel are better?
Now, I think common sense and our personal asthma action plans tell us that patients need to be able to recognize when their asthma is going out of control. And it does not make sense to prescribe these high doses, which are not licensed, potentially dangerous, which mask the symptoms. So the approach, and Andy Bush and Louise and I and a number of other people wrote a letter to the BMJ, must be a year and a half ago, just detailing that this approach does not really make sense. So unless you can prove that it does, and I know we've tried to get funding through a project Sedgel has tried to get funding for, unless we can prove that this system is better than advising patients to use SABA as needed and to call for help if it's not working or if needed frequently, then I think we should be stopping this unsafe practice, in my view.
Thank you very much, Mark. I think it's this question from Manohar. So it's absolutely makes sense to use low dose of inhaled corticosteroids along with short-acting beta-agonists rather than using SABA when necessary. I wonder how widely doctors are practicing this in the UK.
Atul, if we look at COVID as an example, we decided to reinvent the wheel ourselves. We failed to take lessons from other countries and to look at evidence from other countries. The whole world follows Gina except the UK.
Yeah.
And maybe, you know, the differences in asthma deaths may have an explanation. So I think, and the point I made about guidelines not being updated every year does leave us behind. And I think that we need to stay with the evidence. And there are 2 studies now in children. And as you know, there are not many studies in asthma in children. And there are 2 studies which indicate that ICS with low dose, with SABA are more beneficial than SABA on its own.
And Dr. Levy, you also mentioned in your talk that using ICS along with an as-needed SABA as a kind of a maintenance on step 1 works very well, even for children of quite young ages. Prasad Nagakumar is asking whether we're basically therefore looking at SMART and MART regimens for children of all ages under GINA.
There's currently a study of SMART or as-needed ICS LABA in younger children, but the 2 studies that I spoke about address the issues or they include patients of 12 years and over. And there's very good evidence that as-needed ICS formoterol is as good as regular ICS in mild to moderate asthma. We're not talking about severe asthma, but we need to get away from regular use of SABA in mild asthma. And NICE still advocates, if you follow NICE avidly, you could on SABA for a year before you refer a patient to a specialist. So we need to stop using SABA as treatment. It's not logical. Again, it's a bronchodilator, and asthma is an inflammatory condition. So, and I've shown you data that even mild asthma, 1/3 of deaths in children are in patients with mild asthma or so-called mild asthma. Now, I should really say the definition of severity is really based on treatment plus control and not just ACT. It's control overall, including attacks. So if someone's on high dose treatment and they're taking it, they're using the drug correctly, and they're still having attacks, they are poorly controlled. And so we should be aiming to prevent attacks. So by prescribing a drug which just relieves symptoms for 4 hours is not going to achieve very much.
Thank you. I think you made a very compelling case for that.
Thank you very much, Mark. It was an excellent thought and overview. In the sense of time, we move on to the next talk. And the next talk is on transition to the adult care in asthma, the structure, challenges, and the solution. And this is a duo which it's been a duo with Dr. Sab Gray, who you probably saw this slide of Sab this morning. He's a general pediatric consultant with interest in respiratory and asthma in Salisbury, and he's the one who has been moderating the tweets today. And along with is Bharat Reddy from who's the pediatric pulmonologist in Bangalore, and Seb and Bharat has been doing a joint project in India looking at the transition as well, and they would be providing reports on the overview of their initial findings as well. Dr. Seb Gray and Dr. Bharat Reddy.
Thank you very much, Atul. Hopefully you can see my slides and hear me.
Yep.
Thank you very much for the invitation to talk. So I'll be talking about transition of asthmatics to adult care. I will mainly be focusing on the challenges, pointing to some of the holes in the structure and hopefully stimulating some discussion about potential solutions and highlighting of people that may have very good areas of practice elsewhere. If you do want to comment on Twitter, please use the hashtag #DigitalAsthma2020, and there's been lots of great discussions already. So within a medical context, transition is defined as the purposeful planned movement of adolescents and young adults with chronic physical and medical conditions, of which asthma is one, from child-centered to an adult-oriented healthcare system. I'm not sure any of us in the UK can say that we do this well, but it's not just an issue to the UK. I think this is a worldwide issue. And like I said, there may be pockets of excellence. We've heard about some great areas of practice across the country, and I'd be really keen to hear more about them. But I'm here to highlight that in asthma, transition process is really essential. Worldwide, 339 million people are affected by asthma, and there's 5.4 million people currently being treated for asthma in the UK. And despite it being the most common chronic condition to affect children, that's still less than 20% of the asthmatics in the UK are children. And those dying, we know, are disproportionately high in the UK compared to the rest of Europe. We've heard a lot of opinions on why that may be the case, and I strongly feel that suboptimal transition processes needs to be at very least on that list, if not really quite high up it. I think this is probably the 5th or 6th time that Mark Levy's work has been referred to, and I'm going to be highlighting a few more of the details from his very important study. We know that potentially preventable factors were present in 2/3 of the asthma deaths, and there were 28 deaths analysed under the age of 20 in the confidential inquiry out of a total of 195. We know asthma is a treatable condition. We know that people should die with their asthma, not from their asthma. There were 19 recommendations from the NRAD report, which were all really important, but the actual word transition wasn't mentioned in any of those recommendations. Dr. Levy also pointed out the fact that only 4% of those that died under the age of 20 years received a good standard of asthma care overall. And it's important to remember that this is the absolute tip of the iceberg, in that 195 patients out of 5.4 million is less than 0.04%. However, a tiny proportion receiving such a tiny amount of good care is still not good enough. And we want our patient populations that we look after to receive good care all the time, and every single patient matters. It's therefore really important to learn from studies like this and make changes. And unfortunately, this hasn't always happened. You'd be very forgiven for skim reading this abstract and thinking it was about the NRAD report in 2014, but actually this was an analysis from 1979 from deaths in 2 regions from asthma, published a few years later, back when the BMJ was known on PubMed as BRMEDJ. They found 86% avoidable factors in asthma deaths, looking at 90 patients. And the themes and the recommendations are really similar to the NRAD findings, so it's hard to believe that this was 40 years ago and that we haven't really learned from them. It's really clear that we need to learn from this time what's going to change in the future, and we've had some really great talks today about potential ways to do that. But why focus on adolescents? Overall, 65% of the deaths had potentially avoidable factors. Many of these factors were potentially influenced by what is covered in transition. And there was a much higher rate of potentially avoidable factors, 94% in that age group 10 to 19 years. This age group seems much more prone, and there's an opportunity to not just improve the outcomes for this age range, but also by effectively educating and empowering young people to self-care, engage and understand their asthma, we can have much longer lasting beneficial effects. Our current Royal College of Pediatrics and Child Health President in the UK, Russell Viner, has said transitioning of adolescents from paediatric to adult care in an efficient and caring way is one of the great challenges facing paediatrics and health services this century. We know that adolescents are at much higher risk of serious disease complications, and that's due to many factors. Adolescence is the period of our lives where we develop our independence and can find a sense of freedom. Many of us made some really life-changing decisions that affected the rest of our lives during our own adolescence, including going on to become healthcare professionals. But not all our decisions were the correct ones, and for many it can be a time of experimentation, defiance and rebellion. Non-adherence to both medications is also not avoiding the known triggers can result in acute deteriorations. It's therefore a very precarious time. The move over, as you saw from Will's graph, from sharing decision-making with parents to sharing it in a triad model before switching to patient focus is really challenging, and one size does not fit all. Education is absolutely essential to ensure that young people really understand their illness, their triggers and how they can treat it. We heard that 45% of those that died did not call for help or seek medical advice during their ultimate illness, and that's something that can be addressed through effective education during transition. It's also worth remembering, and this has been highlighted already, that 58% of those that died had mild to moderate asthma. It's not just severe asthmatics that die. We therefore need to be cautious as paediatricians that when we transition over to primary care, that we do transition over to primary care and that we don't just discharge and let primary care deal with it. Poor transition can then result in primary care getting the blame for poor future outcomes. For example, from the NRAD study, again, 70% of those managed in primary care had potentially avoidable factors, compared to only 29% of those managed in secondary to tertiary care. At first glance, that suggests that secondary and tertiary care are doing a better job, but how much of that is due to poor transition? Guidelines are either directed at children or adults. You don't go to bed one night as a child and wake up the next day as an adult. Adolescents fall in a grey area, which our guidelines, albeit very good, don't cater for. GINA groups anyone older than 12 with adults. BTS sign a nice group 5 to 16-year-olds all together, and then anyone older as an adult. During a period when you don't want to be treated like a child, but you're not yet fully developed and independent, presents another unique challenge. Research studies have to draw a line in the sand somewhere. But again, adolescence is fluid. There's not one age cutoff where evidence works and then doesn't work. Personal asthma action plans are another clear example where it's either black or white. You have a child version or an adult version, and there may be some pocket somewhere where there's an adolescent version that really works. But when 77% of those that died had no evidence of a personal asthma action plan, this is another area where transition really matters, where we need to drum it home to absolutely every young person how important it is to have this and follow it. Young people are exposed to cigarettes from an early age, and you'll have likely heard Professor Bush talk at some point about concerning incidents of vaping. Twice as many 10 to 19-year-olds experiment and smoked within the last year compared to the overall percentage of asthmatics. It also feels like vaping is going through some form of precocious puberty and is now in its own adolescence. I'm sure you all share the concerns that the impact of the exponential rise and apparent lack of restrictions on vaping in young people could be catastrophic, and we're only touching the edges now of knowing what exactly is going to happen. This is all stuff, again, that needs to be dealt with during transition, and young people warned about the potential impacts. Again, during a time of experimentation, it's not just vaping that people will try, but recreational drug use goes up during adolescence and remains a burden on society. Studies have shown that both cocaine and heroin use in asthmatics increase the intubation risk and ICU admission. You can't talk about transitioning in adolescence without talking about mental health also. We know there's an increased prevalence of anxiety, depression and panic disorders in asthmatics compared to matched controls, all of which can feed into that vicious cycle picture that's been shown in various different forms throughout today. Media plays a massive part in any adolescent's life, and this is an example of where media can give false impressions. I searched child using an inhaler on a search website. This was a few days ago, and out of 22 images, only 13 showed no spacer use. Young people use the internet on a daily basis, hourly basis, and the false information and wrong education that they might get on there can be really alarming. We need to use transition as a method to signpost people to reliable resources. The next generation are very understandably and rightly more environmentally aware than we were. And the carbon footprint of asthma treatment, which we haven't really spoken about today, is quite significant. NICE have very helpfully produced a toolkit to help guide decision making, but there may be some adolescents out there who scrap their metered-dose inhaler for environmental reasons without considering their treatment for an acute exacerbation. In this mainstream article here, published on the BBC last year, they quote that 5 doses from a metered-dose inhaler is the equivalent of a 9-mile trip in an average car. In comparison, using a dry powder inhaler was 1/25 of that. The BBC, to their credit, did point out that dry powder inhalers are only recommended for milder attacks, but how many adolescents and young people do you know that will take out 2 inhalers to wherever they go, just in case they either have a mild or a severe attack? And we need to consider this again when transitioning, because I think this will become more of a problem. We've seen that an elevated body mass index is one of the most significant risk factors for death from COVID. But this meta-analysis and a forest plot here from Fariba Amdazar and colleagues from 7 studies has a pooled odds ratio between obesity and poor asthma control of 1.23. And although there's a slightly overlapping confidence interval, the link is definitely there and has been highlighted before. Again, these are issues that we need to tackle during transition, and I don't think we yet have a process that does that effectively. I'm now going to hand over to my colleague, Dr. Bharath Reddy, who's talking about a study we've done looking at the Indian perspective. So over to you, Bharath. Hopefully you're on the line.
Hi, Seb. Thank you. Thank you for giving the perspective before my talk. And I think this was the study which we did was what me and Seb did after we had a short discussion in the IPA meeting that we met in Istanbul, where we spoke about the need for transition of care in asthmatic adolescents as a global perspective. So of course, this exists in many countries, but like India, many other countries across the world, the concept of transition of care is almost non-existent. As Seb had already given us a perspective on what the definition of transition is and the need for transition of care, we wanted to assess whether doctors, especially pediatricians, as well as adult physicians who were treating asthmatic adolescents had an idea on transition of care of asthmatics, especially in a large country like India, where we see a huge number of asthmatics, both in the pediatric as well as the adult population. So what we did was we went ahead and did a cross-sectional survey, which was circulated through online portals to a database of nearly 320 doctors working in the field of adult or pediatric respiratory medicine in India, of which we got 212 responses. We did see that there was an equal distribution, and we ensured that both the adult physicians as well as the pediatric physicians were equally represented, of around 99 pediatric pulmonary doctors and around 113 adult pulmonologists. So we went ahead and asked them certain questions for us to understand what was exactly happening with transition of care in India, and which could probably be extrapolated for many other countries across the world. So our first question was, is there a need for transition of care in asthmatics itself? And we see that nearly 81.5% to almost 82% of the respondents felt that yes, it was extremely important for asthmatics who were under the care of pediatric respiratory physicians to start transitioning to adult respiratory physicians with age. Now, let us note that in India, this concept was completely new. This was probably the first study which was done, and many doctors were hearing this also for the first time. So the next question of what age should this transition happen? Nearly 70% of doctors, especially adult physicians, adult respiratory physicians, felt that the transition had to happen by 16 years of age. And 18.5% of respiratory physicians agreed that the child needed to be transitioned before 16. So here, though we had both the groups sitting on the same table, there was a very big difference in opinion of the age at which transition should occur. Now, let us not forget that if a uniform transition process was not happening, many of these patients would probably get missed in the process. Many of the patients were fending for themselves to get their proper transition from a pediatrician to an adult physician. The reason why this was again important for the physician to make a decision at what age the transition should happen is because a lot of decisions in India especially is still left on the physician, and the physician has to initiate this process. So we realized that almost 77% of pediatric respiratory physicians felt that we should transition between 16 to 21 years of age, of which another 50% of them were very clear that the ideal age for transition should happen between 16 to 18 years when this process has to be initiated. Although this difference was seen between both the groups, almost 85% of both groups agreed that the transition process in India was average to very bad. And this in itself put us on a limelight to say that we need to handle the next issue in place of placing guidelines. So what are the problems which were faced in transition of care for respiratory issues and especially asthma? So asking these doctors on what the problems they faced could probably give us an idea on what we need to work on. And as you can see, the most common problem, which was uniform across both adult and pediatric respiratory physicians, was a lack of communication. And this, as we know, is one thing that we as pediatricians need to focus on, especially not only communicating with our patients. Of course, we are communicating with our patients very well, communicating with parents. But what about communicating with the adult respiratory physicians who are going to take over these cases in the future? And almost 86% of them felt that there was a clear lack of communication between both these groups. The second most common problem, which a lot of doctors felt on both groups, was that parents preferred to continue with a pediatric specialist. And this was more what the pediatricians felt, that parents were not ready to go to an adult physician. Even at the age of 16, even at the age of 18, many felt that they were still comfortable. The parents especially were more comfortable with a pediatrician. This again brings us to the point that communication and counseling by the pediatrician on why a child needs to transition to an adult physician, on why an adolescent needs to start transitioning to an adult pulmonary physician is very important. It is important for us as pediatricians to hence start this counseling with our adolescent asthmatics as well as their parents on the importance of transition. Other points such as complex respiratory issues not being handled, genetic issues not being handled, were all not given as much importance as these two major points which needed to be addressed. Going on to what were the differences in management of asthmatic adolescents, we do see that almost 80% of all, both pediatric and adult respiratory physicians, did agree that adolescents are a difficult group to manage. I think Seb has highlighted all the points on why adolescents are such an important group for us as asthma physicians to talk about on the physical and psychosocial changes. And I think 80% of us agree that it is important. What was very important was that nearly 59.6% of respondents felt that the protocols followed by pediatric as well as adult respiratory physicians were very different. 18.7% were undecided, which brings us to say that nearly 78 to 80% of both groups do feel that the protocols which were followed by pediatric and adult doctors were very different. So what was the difference that we wanted to see? So we did see that, yes, were asthmatics compliant or not compliant? We all realized that 69% did feel that yes, asthmatics can be compliant with parental involvement. So yes, all of us, both the adult and pediatric respiratory physicians, wanted to get parents involved to improve the compliance. But what exactly can we do with respect to the difference in treatment? So we analyzed what was the difference in the treatment. We saw that the most common drug, surprisingly, which was used was budesonide formoterol. Almost 63% of respondents said that they used budesonide formoterol as the first drug of choice, especially in asthmatic adolescents. And if you look at monotherapy with ICS, it was very less. Almost 11.6% used budesonide and only 3.3% used fluticasone. But what we also realized that adult respiratory physicians preferred to use budesonide formoterol, almost 76.6%, compared to pediatric respiratory physicians, which were only 48% who preferred to use a combination therapy. Going on to the device which was used, was there a difference in the device which was used? 58% of all respondents said that in an asthmatic adolescent, they would use MDI with spacer. But we did see that there was also other devices like rotahaler, turbohaler, autohaler, or MDI alone, which was used. And the difference over here, which was noted in our study, was that adult respiratory physicians preferred to use devices other than just MDI, like rotahalers, turbohaler, and autohalers, whereas pediatric respiratory physicians preferred to stick to MDI with spacer. So these 2 points did show that, yes, there was a significant difference in the treatment drugs as well as the devices used between both adult as well as pediatric respiratory physicians. What about management with spirometry? Were all of them doing spirometry? Only 44% of respondents said that they were doing spirometry in adolescents before initiating therapy. Another difference we noted was 87% of the respondents who did spirometry were actually adult respiratory physicians, where only 60% of them were pediatric respiratory physicians, which again showed that adult respiratory physicians were performing spirometry more frequently than pediatric respiratory physicians, which could pose a problem again during transition. Because once this transition happens to an adult physician, you would see that a lot of spirometry was not done, which gives us as pediatric respiratory physicians an onus that before we transition, spirometries need to be done in our pediatric patients. On follow-up, we saw that adult respiratory physicians again performed more spirometry routinely than pediatric respiratory physicians. So what are the main components that we need to talk about? I think Seb has covered about all this, but in our survey, I think uniformly 80% to 95% of all doctors agreed that the asthma action plan was the most important component that needed to be included in transition care. Other things such as inhaler technique, environmental triggers, allergen sensitization, and how to manage an acute flare-up was given importance, but the most important thing that we needed to communicate to the patient as well as the adult physician was in personalized asthma action plan. So we also went ahead and did a qualitative analysis. We let the physicians talk about it openly as to what they felt was the main problem in transition. And if you can see, both between pediatric physicians as well as adult physicians, there was a uniform word which was used, that there was a lack of guidelines, there was a lack of any set protocols on how transition had to happen in India. And this, I think, is something which across the world, a lot of doctors have been spoken about. One of the important points also raised that international guidelines themselves do not focus about transition of care in asthmatic adolescents. Then how are pediatric and adult physicians going to talk about it? So yes, this brought us to the next and most important point on how are we going to go ahead and do this. So this study, as you know, laid the foundation for us, and it also showed that there was an appetite from both groups, both the pediatric as well as the adult respiratory groups, to sit down and talk about and lay down a process on transition of care in asthmatic adolescents. Through our study, we have shown that yes, there is a need for both groups, pediatric and adult respiratory physicians, and not just a single group to sit down and create national guidelines. And we hope that this study also forms a base for international guidelines on transition of care in asthmatic adolescents. Thank you.
Dr. Gray and Dr. Reddy, thank you so much for a real worldwide perspective on a particularly challenging patient group. I'm aware we don't have a huge amount of time for questions. I just wondered if I could ask you, Dr. Gray, about, obviously Dr. Reddy was highlighting the problem with transitioning from pediatric to adult lung specialists, which is quite more common in India, whereas we're generally transitioning children from secondary tertiary care into primary care with asthma. Any particular personal strategies you use to optimize that process?
Well, absolutely. So I think we actually, and I think there's a big to this as a nation, to try and collaborate more with primary care. In an ideal world, we would have at least 2 or 3 joint appointments with the pediatrician or respiratory pediatrician and the GP, with some form of link. But that can only really seem to happen with funding in the big teaching hospitals. And as a district general hospital general pediatrician with a respiratory interest, I don't even have a respiratory specialist nurse. I have an amazing physiotherapy colleague who does the job for about 3 or 4 people, but I don't have a respiratory nurse. And I think the key to developing things further in the UK will be working closely with primary care. So I think that's fundamental.
Thank you, Seb. And Bharat, moving to same themes, I believe some of the patients with asthma are probably mild enough and they would need to be transitioned to the primary care. Are you trying to look into that part of the loop as well?
Yes, Atul, of course. So I think we're going to be addressing that especially in the guidelines that we're planning to make. Step that has already been initiated, where we've called in both the adult respiratory group as well as the pediatric respiratory group to come as a single group to address all these issues. So talking about how mild asthmatics need to be transitioned or not, I think we will be defining very specific criteria which will help a pediatric respiratory physician to decide who needs to be transitioned and who need not be transitioned. So I think clearing this guidelines and clearly defining this would help the pediatricians a lot.
Thank you. I think for the sense of time, we move on to the next talk. It'll be quite nice to finish on time for everybody, especially being a Friday. There are a few questions, Bharat, and
Yeah.
for you. Would be grateful if you could type the answers for them.
Sure.
If anybody
Thank
else
you.
wants to ask any other questions to Seb and to Bharat, please free to type and ask them. Thank you very much again.
Thank you. Thank
you. Now, moving on to the next talk by Dr. Prasad Nagakumar. Prasad is a consultant respiratory pediatrician at Birmingham Children's Hospital. He's lead for the diffuse and severe asthma and has been quite active over the last 6 months, looking with the COVID and how that has changed the asthma management. And he is now going to talk about how to avoid back to asthma attacks. September is the month in the UK we see maximum amount of asthma attacks, and he has a plan how we can avoid the asthma exacerbations when children go back to school this week and the next week. Dr. Prasad Nagakumar.
Thank you. Thanks, Atul. Thanks for the invite. And then a number of things. What I'm going to talk about is perhaps going to be a repetition from people you have heard before, but at the end of a really long and interesting day, it'd be nice to sort of finish off by summarizing what we've discussed. I'm going to discuss the direct and indirect effect of COVID-19 on children and young people with asthma, and then perhaps concentrating a little bit more on the indirect or the collateral effects of COVID-19, and talk about acute asthma management. As you highlighted, September is a month where we tend to see quite a lot of asthma attacks in this country. And we got an international audience, but the talk is predominantly be based on the UK practice. We know that COVID-19 infection is rare in children, although there's no quality data of COVID-19 infection rates in children with asthma. I think our general practice indicates that we're not seeing many children with asthma presenting with severe or even sort of mild to moderate COVID infection. There is emerging data from the adults, the clinical data. It's known that well-controlled asthma is not a risk factor for severe COVID infection. There are some discussions if uncontrolled asthma, recent courses or repeated courses of oral steroids in asthmatic adults, whether it predisposes to severe COVID infection. However, there is also a data which has been sort of published showing that if you look at people who were admitted, adults who were admitted with COVID-19 infection, asthma, who had asthma, this was not associated with worse outcomes, even when they're corrected for things like ethnicity and obesity and things like that. So we are getting a lot of information about the impact of COVID-19 on asthma. I just want to highlight this in vitro study, an interesting data which has been published recently, looking at the expression of ACE2, which we all know is a receptor through which it's postulated that the SARS-CoV-2 virus gets into your lung cells. And this is the data from lung epithelial, both upper and lower airway cells from 11-year-old asthmatics. And what's interesting is that the study has shown that children with atopic asthma, i.e. who have the Th2 kind of a phenotype, they do have a lower gene expression of ACE2. In a way, in vitro studies showing that perhaps there is a little bit of a protective effect of having asthma, particularly the type 2 inflammatory type of asthma. And more importantly, the level of this ACE2 gene expression was associated with sensitization. The higher the number of, the higher the degree of sensitization, allergic sensitization, they seems to have result in lower ACE2 gene expression. We talked about the disease. What about the treatment? Obviously, earlier on into the pandemic, there were a lot of controversies around the role of inhaled steroids in general. But there are mechanistic studies which are coming out showing that perhaps using budesonide and formoterol, it has a suppressive effect on the viral replication. And there are more recent studies from America looking at big numbers of sputum cells in severe asthmatics, showing that those who were on high dose of inhaled steroids seems to have a lower expression of the ACE2. However, this is in sputum. So having this kind of a background information is quite crucial, because as healthcare professionals, we do have our own beliefs. And when we talk about sort of what we advise our families, most of a number of us, we have got our own children who are going to school. And this is quite important to understand the shift and the important information which are coming through in terms of the effect of COVID-19 in asthma. And what's kind of in a way this has resulted in is there is an ongoing study coordinated by Oxford, where they're looking at use of budesonide in adult COVID-19 positive patients, where they're recruited quite earlier on when someone is when someone tests positive. They are recruited, they are randomized to receive a placebo or a budesonide for 4 weeks. And the idea is to see whether giving them inhaled steroids, these are not asthmatics, this is any adult sort of who fulfill that criteria for the study, to see whether that results in reduction of the severity of COVID-19 infection. So there is a big shift in the paradigm in terms of the role of inhaled steroids, which obviously has impact on what we discussed today regarding asthma. And this has been discussed before. Moving on to talking about, we talked about the direct effects of COVID-19 on asthma in children, which is very minimal. But what are the collateral effects? And the main silver lining for us has been, we have seen significant reduction in asthma attacks. I know Andy had talked about it before. This is the data from Public Health England, looking at the children presenting to emergency department with asthma attacks, which is down significantly in the month of June. And the dotted line is where you would have normally expected at this time of the year. And Atul and I, we looked into the emergency admissions within our emergency departments at Birmingham Children's and at King's College Hospital. And the dotted bars are from 2019. If you look at March, April, and May, 3 months, there is the compared, and if you compare this to 2020, which are this small boxes here, there is a significant reduction in children presenting to emergency department. So this covers most asthma, whether you label them as mild, moderate, or there's also perhaps covers also kids with pre-skill Vs. What do we know anything about children with severe asthma who are on biologics, how they have behaved during pandemic? And again, Atul and I were able to collaborate. We looked at 34 children who are on biologics in both the centers. As part of their assessment for any child being on biologic therapy, we review, we get data about their asthma control test. And of course, due to pandemic and the way we were managing these children, we don't have the lung function data, but we are able to measure asthma control test and look at their exacerbations, the number of asthma attacks they're having. And this is quite important because in this study, which is under review in the journal now, we defined asthma attacks as even someone who needs oral steroids, because there has always been this discussion that for a number of reasons, perhaps the family are not able to come to the hospital, or the child might be having mild asthma attack. They call up their primary care physician and they're dispensed oral steroids. And that's not the case. If you look at the asthma attacks, out of 34 children, 19 of them, they had at least one asthma attack during November and February, November 2019 to February 2020, that's pre-COVID, 4 months. And when we looked at a similar data 4 months into the COVID era, 13 of them, they had no asthma attacks during this period. this is defined as not even having even a single short course of oral steroids. And we also noticed that in around 15 children who had a lower asthma control test, a median asthma control test 4 months prior to COVID, even they had a significant improvement, which matters clinically. These were having median asthma control test scores of 15, while 19 is your cutoff. They all improved to 20. So you might wonder what some of the treatments we are giving doing to these children, but actually there is a big change showing that even in a severe asthmatic children during COVID period, they had significant reduction in asthma attacks and better asthma control. And I know this has been highlighted before. There are a number of reasons why this could have happened: less viruses, less pollution. And more interesting thing is there's data coming out showing that more people quit smoking during the lockdown. Whether that is going to be sustained now that people are going back to the normal, whatever the new normal activity is challenging, but there is some data showing that. And there's also some data showing that there is improved adherence, particularly in adults, asthma and COPD patients, which may have also reflected kind of in a way in children. This is the data from America, electronically monitored adherence, where they looked into their asthmatic and COPD patients. By the way, this is an adult data showing that around from March, there is a sustained increase in the adherence to the inhaled steroids. So it is multifactorial, and it's quite important for us to understand this when we move to the next phase of how what's the future and what are we looking for. And I think this is all obviously guided by or influenced by the collateral effects. We talk about, particularly when we talk about the difficult asthmatics or severe asthmatics, kids who had frequent asthma attacks. They're on a lot of asthma therapies. They have multiple comorbidities. And what's clear is it's been highlighted even before. One size doesn't fit all, because asthma is a heterogeneous condition. It is defined by symptoms. There's no gold standard test. So saying that there is one intervention which is going to make a massive difference, I think it's quite difficult. That shows that perhaps we have overestimated or underestimated the other comorbidities, particularly in children with severe asthma. So coming back to the context of COVID-19, the collateral effects, there have been a huge impact on the emotional well-being on these children. These things are quite important when we talk about how we manage these children in September and to coming months. The sleep hygiene has been disrupted a lot. Teenagers, normally they go to bed at 1 o'clock, but they would be woken up at 7 or 8 o'clock to go to school. That hasn't happened. Obviously, that has a lot of implications. And these issues have been highlighted recently in terms of how much COVID-19 had collateral effects on children and young people's normal day-to-day activities. Physical activity has gone down, weight gain, and it's from personal practice. Although we are seeing them virtually, we are not able to appreciate how much weight they have put on. You see them face to face, and then you can see there's a massive amount of weight which these guys have put on. And we talked about, as you said, this is for a number of reasons. But when kids go back to school due to change in weather, issues with adherence to the medications during summer holidays, a number of factors result in surge in asthma attacks in September, and we need to see how this pans out. And clearly, looking at the data in my hospital over the last week or so, we already started seeing more kids coming with issues with asthma. Certainly, there has been a surge in the numbers we are looking at. And more importantly, the change in care delivery. I mean, we have changed a lot during how we deliver care during this period, and how does that impact on these children and young people. And this has been discussed a lot. Clearly, whether we like it or not, COVID-19 is going to have a significant impact socially and economically, and certainly on our most vulnerable population. This is going to have a big impact. And the interesting thing is, what about hand washing, wearing masks? How does this have impact on the winter viruses? Are we going to see any difference? Is there going to be a reduction in the number of common viruses we tend to see? And there is some data showing that perhaps there is some reduction in other countries, but we just need to watch and see how things pan out. And these things are quite important for us in working through how we manage asthma in coming months, particularly the asthma attacks. Nadia has done some fantastic work looking at the emotional impact of COVID-19 pandemic and lockdown in children with problematic severe asthma. This data is from King's, which has been peer reviewed now. And what is very clear that there has been a significant impact on COVID-19 and its lockdown on children's mental health. There is difference between perception of what the parents think of and the children, but overall, they're all worried about the asthma attacks. They're worried about going to the hospital because of the risk of catching COVID and the anxieties around it. They're worried about how they're going to cope at school, how they're going to cope with social distancing, and the significant impact, as we talked about, sleep problems. It has resulted in anxiety, irritability in a number of these children. And what's interesting is that children, they were less concerned about access to medications because obviously it's the parents who pick it up and probably they ask them to sort of take the medicines regularly. And they're less worried about catching COVID infection, which is slightly different to what the adults, what their parents perceive. So there is a big impact emotionally, and we're getting objective data now rather than sort of assuming a number of these things. So taking into consideration whatever we discussed before, I think we have to go back to what we're doing. There have been a lot of improvements. Things wouldn't have changed in 20 years in terms of how we provide care. We're able to transform in few months. So we need to carry on with the good work, but let's not lose the focus. The key issue here is that reassuring the families, support them in terms of sort of kids going back to school, making sure that they got a right asthma plan, making sure they're on the right medications, and also encouraging self-management. Flu vaccination in who are entitled to is quite crucial, and we need to keep on supporting the families in terms of smoking cessation wherever it's applicable. And the key here is we got additional comorbidities which we wouldn't have had every September. These are not new, but perhaps they were not that significant or perceived to be significant. And it's quite important for us to address this, particularly when we see a young person. Obviously, they all had issues with, a lot of them had issues with sleep. And it's quite important for us to, whenever we have contact with the young people, to make sure that the sleep hygiene sort of is good. We need to have a structured program about physical activities, weight management. Just referring to the dietitian is not enough. Because obviously, usually it makes no difference. And more importantly, working through supporting them with their emotional well-being. And these factors are all really important for us to address on top of our basic asthma management in preventing asthma attacks, in particularly in our difficult asthmatics. The other thing what we wanted to discuss was that earlier on in the pandemic, there were a lot of anxieties and issues around availability of personal protective equipment, anxieties about the aerosol generating capacity around the nebulizers. So we had a lot of questions about people wanting to change the way the acute asthma management is done. Instead of using a nebulizer, can we give them iron magnesium sulfate as the first line? Can we give them inhalers? And I think that's what we prompted Atul and I, along with my colleague Ben, to write a review article, just looking at the evidence for the asthma management, and nothing has changed. It's still the same. We talked about salbutamol. In an acute, when someone is having an acute asthma attack, salbutamol saves lives. If someone's saturation is monitored and it's less than 92, they need to have it administered by nebulizer. And having aminophylline and magnesium sulfate is key. It has to still remain as the second line. And early administration of oral steroids, I think it's quite crucial. So this is what we highlighted in a review which we have recently kind of published in archives. And as I said, COVID has brought in a lot of good things, and we need to work and make sure that we don't inherit some of the things which we wanted to sort of in a way bring it in so that it becomes a norm. We always have to go back to the evidence, what we have, or the best evidence we have, and then carry on managing them. The current, for the acute asthma management, when you see a child who's unwell, having an asthma attack, discussing its limitations, the BTS guidelines is still sort of a standard and we need to follow. Where we need to focus on is preventing further asthma attacks, and more importantly, understanding the risks involved for repeated asthma attacks. We know that poor adherence to treatment, comorbidities, and previous asthma attacks, they do pose a risk. And it's quite important for us to understand, just not leaving it to primary care or a specialist center or a secondary care, that shouldn't happen. It's all our responsibility to make sure that whenever we see a child whose asthma is not well controlled, it's all our responsibility, whoever sees the child, to make sure that the child is on the right medication, it's on the right dose, they're taking it properly, they got a good monitoring in terms of follow-up. Saying that, okay, you come to the hospital, I'm going to discharge you, go back and see your GP in 2 days, or come back and see me in 2 weeks, without addressing these issues, it's not the right way forward. And I hope that that's going to be one of the things which is going to come as a positive sort of effect of the COVID pandemic. And these things, we know, poor improper inhaler technique, inhaler devices are quite crucial. And hopefully, let's hope that even Daily Mail or any of the tablets will start using the right type of sort of inhalers. So again, nothing drastic, but going back to the basics and reminding ourselves that sort of what we're doing, some of the good things, what we're doing pre-pandemic, we need to carry on. To summarize, I think it's going to be a very interesting but challenging times ahead. As I said, sort of the information we have now, asthma is not a risk factor for severe COVID infection. And I think focusing on the basic asthma management and preventing the asthma attack is quite crucial. And we're going to have issues in addressing the comorbidities, particularly with sleep hygiene, emotional sort of a well-being, and exercise, which we need to address in our different asthmatics, and also support our families with the information we have. And as I reiterated, it is not okay for anyone to have an asthma attack just because they got asthma. You wouldn't see someone with the diabetes coming with 8 DKA attacks in a year. You wouldn't see an epileptic needing midazolam every day, but it's quite common for us even now to still see children presenting with asthma attacks 7 or 8 times a day, 8 times a year, and that shouldn't be normal. And we got good resources. This is something which I like. Anne-Marie, she has worked on it. A simple advice to the families, providing them with reassurance and also information about how to manage asthma, particularly when kids go back to school, is quite important. Thank you for listening. I'm happy to take questions.
Thank you, Dr. Nagakumar, for such an insightful and topical talk. I'm really fascinated by the fact that COVID's managed to achieve something that we're all working for, but haven't, in increasing adherence by quite that much. Is there any data kind of for that being an ongoing, sustained thing, or was that just a blip? And any ideas about strategies that we could use to kind of continue to harness that effect?
I think it's a really good question. Sometimes what I find is for families, showing them this data visually does make a difference. And then perhaps I think that's the reason why sort of in a way we're working on getting more objective data about the real impact, showing that, look, you are one of the dots, what I've showed you here. You've done so well. Why is that? Why can't we kind of carry on doing it? And I think working with the individual needs of a child and their family, I think it's going to be crucial. And yes, I mean, I think sort of in a way, perhaps, as we said, sort of in a way, the whatever changes we are making during this pandemic, I suspect that it's going to have sort of in a way sustained positive effect.
Thank you, Prasad. I think we probably have time for a couple of questions. So preschool Vs is something we haven't covered today. So should, especially the management you're focusing on, treating acute attack under 5 years differently from the asthmatic acute attack? And again, the supplementary question to that is, what is your take on oral steroids in an acute wheezy attack in under 5 years? As Sejal Sajlani's paper says, that oral steroids are not helpful in under 5.
It's a really good question. Preschool Vs, I mean, sort of in a way, if you think school age asthma is an enigma, I mean, welcome to the world of preschool wheeze. So it is interesting. I think I suspect we need to have a higher threshold to look at the other differentials. I don't know whether other people have noticed. We have, about other units have noticed. We have seen a significant increase in foreign body inhalation over the last sort of a few months. Now, if you look, as it happens, some of them, they've been in and out a couple of times, thought managed as preschool wheeze. What I'm trying to say is the other diagnosis, rather than labeling them as preschool wheeze, I think is going to be crucial. Now, the question of if you're sure about this is genuine preschool wheeze and there is nothing else going on with this child, I think if the child is unwell, I would treat them. If you got someone who's got sort of low oxygen saturations, you have to, I think, manage them with the bronchodilator, because it's such a heterogeneous condition, particularly in preschoolers. I think in terms of using the bronchodilators, that would be what I would do. With oral steroids, again, I agree, it is controversial, but again, it should depend on the child. If you're thinking about admitting a child, then I think I'll have some lower threshold to give them oral steroids. If you're thinking of sending the child home, I don't think the child would need kind of steroids. And I think that's where probably the distinguish sort of clinically, that's what I would make. Or someone who's admitted to obviously HDU, or you're going to keep them in the hospital. I think that's the group where perhaps I would use kind of oral steroids. If you're sending them home, if you think they got mild wheeze, they're drinking fine, they're active, then I don't think sort of there is any indication for giving oral steroids.
Thank you. There's also a bit of a theme on the chat, which is asking you to look into your crystal ball a little bit unfairly. But several people are interested in whether you think that social distancing measures, increased hand washing, mask wearing actually might flatten the September peak quite significantly.
It's a really interesting question. I wish I would have a crystal ball. There is some data coming from published in adults. I don't think sort of in a way that there is certainly a reduction in the number of flu cases which people are seeing, say, for example, in Italy, Australia, and Northern America. But obviously there is going to be a little bit of a lag. And let's hope for, I think sort of in a way, it's what we're doing perhaps is unique to a virus. These measures, what we're doing is what probably would have done with any kind of a contagious illness. And I'm hoping that we are going to see kind of in a way less viruses over the next couple of months. But it'd be really interesting. That's the reason why I said it's going to be quite challenging, but really interesting next 3 months.
Thank you very much, for the excellent talk. There are still a few questions there, and would be grateful for you to type the answers for them.
Thank you. Thank you.
Moving on to the next talk, and perhaps some of the areas which we had discussed, and we talked about the problems, and perhaps not focused much on the solution. And Jen Townsend from the Newcastle Children's Hospital. Jen is a consultant pediatrician with interest in respiratory medicine, and she and her colleagues has developed a Beat Asthma program, which has shown to be of huge amount of benefit. Dr. Jen Townsend.
Can you hear me?
Yeah.
Yeah, okay. So Atul, thank you very much for giving me this opportunity to share with everybody the work that we've been doing in the Northeast in terms of standardising asthma care, empowering patients, and ultimately improving outcomes. The aims of this presentation are that by the end of it, people will know a little bit more about Beat Asthma and what it's done for us in the Northeast, and maybe even find bits of it that might be useful to them in their practice. We're going to talk about the Beat Asthma training days and where we're going to go in the future in terms of Beat Asthma. So as Atul said, I'm from the northeast of England. The northeast is famous for its beautiful quayside, some of the most stunning coastlines in the country, and high quality television programmes. But we're here today to talk about asthma, and unfortunately the northeast has a claim to fame here too. We are amongst the worst in the country for unplanned hospital admissions due to asthma. We know an unplanned admission is a risk factor for more asthma attacks and also a risk factor for death. And as we all know, behind every statistic, there is a story and a family. So I'm going to introduce you now to Dawn. Dawn knows that we're here today and she wants you to hear her story.
Tamara Mills was 13 years old when she had a fatal asthma attack.
I had to physically lift her from the bed into the wheelchair to get her in the ambulance. They'd already given her adrenaline by this point as well. And then Tamara passed out. Never woke up. All I remember was the machines. Hearing that breathing and then the beeping. And then the model grey and she'd gone.
Many of you will be familiar with Tamara Mills, and I know Mark mentioned it in his talk. Tamara died in the same month that the NRAD report was published, and the coroner concluded that the same failings that had been highlighted in the NRAD report had also contributed to her death. Her care had been fragmented. Tamara had sought medical attention 47 times in the 4 years leading up to her death, but nobody was coordinating that care to see that it represented a deterioration for a chronic condition. Simple interventions known to improve asthma outcomes, like the use of asthma action plans or inhaler technique assessment, just hadn't been done. And there was a lack of appreciation across the board, from health professionals to Tamara's family to Tamara herself, that asthma can still kill. And since Tamara's death, unfortunately, this has happened time and time again. We needed to change the way that we were delivering asthma care in the northeast of England. We needed to improve education of healthcare professionals so that they knew the guidelines and they knew what to do, but also of parents and patients so that they could feel empowered and able to self-manage their condition. And crucially, care needed to be coordinated and seamless from primary to tertiary care with a lack of barriers between services. The outcomes that we would use to measure our success was primarily a reduction in unplanned hospital admissions. These had been increasing year on year by 30% in the 3 years prior to our interventions. We also wanted to increase the number of asthma action plans that people had and improve asthma control overall using the ACT score, with a 2-point increase being a clinically significant change. We used an experience-based co-design approach so that we could design interventions with staff and patients in partnership. So the first thing we did was develop a regional partnership of health professionals from primary to tertiary care, as well as school representatives and pharmacists. And together we identified key problem areas and together found workable solutions that were acceptable to everybody. We ran focus groups with key service users. Families told us that they felt isolated, that people didn't understand the impact their condition had on them, and they wanted resources to help explain asthma and also to help them manage their children's asthma that they could share with family and friends. Primary care told us they would welcome a standardised approach that would allow them to meet all national recommendations easily, but this needed to be easily accessible and for use with patients during their consultations. And finally, as we've heard earlier on today, young people have very specific needs. So we spoke to them too, and they told us they felt frustrated, that people just didn't understand the seriousness of their condition. And they wanted resources that they could share with their friends, ideally via social media, that would help their friends understand as well as support them in managing their asthma. And a theme that came up repeatedly was that of schools. Young people told us that they were frightened to go to school because they didn't believe that staff there understood the condition or would know what to do if they were having an asthma attack. We knew that we would need a multifaceted approach, partly because we were trying to reach different groups of people, but also because what we were fundamentally trying to do was change behaviour. And there's good evidence that if multiple interventions are done together, then they knit together to form a new social norm that promotes a sustained change in behaviour. So from this, we developed the BREATHE interventions, beating regional asthma through health education. The foundation to all of the breathe interventions is Beat Asthma. Beat Asthma is a web page with over 150 resources tailor-made to the people that are going to use them. And there are different portals of entry depending on who you are. So if you're a young person with asthma, you go into your particular area and it brings up a library of different areas that might be of interest to you. For example, if you want to know more about how to manage your asthma, you go in and there's lots of resources, for example, to help you identify if your symptoms are due to asthma or maybe anxiety, the effects of smoking or air pollution, how to keep safe on a night out if you've got asthma, as well as lots of videos and information sheets for the different inhalers. Similarly, if you're a secondary care health professional, you go into your particular area and again, it opens up a library of different areas that might be useful. For example, if you've got a child who you think might have asthma, you go in and it gives you resources, for example, how to make an asthma diagnosis in secondary care, alternative diagnoses to consider, red flags. And then if you think they really do have asthma, information leaflets, asthma action plans, and lots of videos and information sheets. This is just an example of some of the resources that we have on the website. This is our personalised asthma action plan. It's a Beat Asthma action plan, but the top right-hand corner can be changed to whatever logo the trust is. We've got information leaflets. This is an example of a flow sheet of how to do an annual review and a video. One thing that's been particularly popular with the young people has been our Beat Asthma business cards. They tend to put them in their phones, on the back of the phone, particularly if they've got a clear case. And if they or their friend scans the QR code, it takes them directly to a flowchart for how to manage an asthma attack in the community. And the young people have really liked these, and we hand these out in clinic. So having developed Beat Asthma, we then did a number of different interventions. We ran some regional asthma educational days using the Beat Asthma resources as a foundation, and these were attended by over 150 healthcare professionals. We developed a nurse-led one-stop shop clinic that took referrals from both primary and secondary care and allowed all the fundamentals of asthma management to be carried out in one sitting. This in particular was really popular, with feedback saying it was the single most useful appointment they'd ever had for their asthma. We developed a local specialist asthma service that was run by a paediatrician with special interest in asthma and supported by an asthma nurse. And we also changed pathways from when children presented hospital with an acute asthma attack. So at the point that they were discharged, they were given a discharge bundle with lots of information and resources to help them understand their asthma. And this was followed up 48 hours later to make sure that their asthma was actually settling and to look at that asthma in a more chronic way. And finally, we worked with local authorities and delivered cascade training for schools. So what impact did we have? Well, you remember we were trying to reduce primarily unplanned hospital admissions, which had been increasing year on year by 30%. In the year after our intervention, we reduced unplanned hospital admissions by 29%. And this was on a background 10% increase region-wide. And this reduction has been sustained for the last 3 years. And this is the equivalent to over 100 children not presenting with an asthma attack in Newcastle alone, and a cost saving of £67,000. We increased the use of asthma action plans in primary care by 48% and in secondary care by 40%. And then we had an improvement in the ACT score by an average of 6 points. And you remember a 2-point improvement was a clinically significant change. The Beat Asthma website has been hugely successful. We've had over 35,000 page views worldwide and 100% positive feedback from all the different user groups. In terms of reach, every secondary care trust in the North East and North Cumbria is now using the standardised Beat Asthma paperwork and resources. So a child will get the same approach and the same information given in the same way, whichever hospital they go to in the region. We've also got an increasing number of primary care providers also using the Beat Asthma paperwork. We've also had some national interest into Scotland, out to the Isle of Man and down to London. We've been lucky enough to win some awards. We won the HSJ award last year. We're finalists in the BMJ and Bright Ideas and Health Awards, and I've just been announced as finalist in the Patient Safety Awards this year. So we knew we had a successful intervention, but we wanted to do more. We knew that by giving people educational resources to read, this would have some impact, but it would be far greater if we could deliver this face-to-face with the opportunity for discussions and questions. We also wanted to reach further into primary care because any impact we'd had here really was just through word of mouth. And we were really interested in what the young people had told us about schools and whether this was an area of unmet need. So thinking about the education, one of the NRAD recommendations was that all children should have an annual review with a healthcare professional who has had training in paediatric asthma in the last 12 months. But when we looked, there was very little that would allow health professionals to meet this recommendation, particularly with regard to just the basics of asthma management. So with this in mind, we developed one-day courses, both for primary care and separately for secondary care health professionals. The aims of these courses was to improve knowledge of the guidelines and also the NRAD report, and also develop specific skills in the different devices and how to give them, as well as the objective measures like peak flow and spirometry and FeNO. We also looked at improving management in a more chronic way and how to tackle the more difficult and challenging teenager. But ultimately, what we wanted to do was deliver a long-term sustainable change in the way health professionals deliver paediatric asthma care. The structure of the courses is some lectures, skills stations, a shared experience session, and a final end of day assessment scenario that consolidates everything that's been taught during the day. But this is delivered in an environment that replicates the candidate's real life work setting. The feedback from the courses has been fantastic. It's all been positive, and a few people have said this should be mandatory for all people who look after children with asthma. Prior to COVID, we had 5 more courses booked across the country, and we're currently working with Pharma to try and expand this further. So then thinking about primary care, whilst we'd had huge success in secondary care, actually we knew that a significant number of those that died were actually primary care patients. What we needed was a tool that would allow GPs to identify children on their list who are at increased risk of adverse asthma outcomes. And then they could be offered the structured breathe interventions. At the same time as we were delivering Breathe, another initiative was being developed further south in the region by Catherine Eastham in Sunderland. She developed Pdata, the Pediatric Emergency Department Asthma Assessment Tool. And this is a digital triage tool that successfully identifies those children presenting to the emergency department with wheeze who are at increased risk of adverse asthma outcomes. And it does this by asking 4 key questions, which are: has the child in the last 12 months had 1 hospital admission, 2 courses of steroids, 2 asthma attacks, or more than 12 SABA inhalers? And if the answer to any of these questions is yes, then they are then automatically offered an appointment in a nurse-led clinic. And the 1-year data from this pilot has shown a phenomenal reduction in hospital admissions by 71%. So with the support of the AHSN, PDAT has combined with Beat Asthma to form Beat Asthma Plus. And Beat Asthma Plus involves a digital triage tool, which is based on PDAT, but has been adapted for primary care and then is embedded into GP IT systems. So this then automatically identifies those children at increased risk of adverse asthma outcomes. And they're then invited to join a new pathway, which involves more frequent reviews and the breathe interventions. The aim of Beat Asthma Plus is that all children in a GP surgery at risk are identified, and they're then offered a standardised approach both to diagnosis and management. And the aim is that by targeting those most at risk, resources can be targeted in a more structured way, and there can be improved asthma outcomes for everybody. The outcomes we're going to use for success for this project is again a reduction in unplanned hospital admissions, but we'll also be looking at some secondary outcomes. In order to make sure that all potential barriers have been identified, as well as to get valuable insights and ideas from the people that would use Beat Asthma Plus the most, we ran some focus groups. Families shared with us their frustration at being unable to access care for their child when they felt they needed it. And they also really had a desire to have resources that would help them understand the child's asthma and how to manage it. The support and enthusiasm for the project from primary care has been really overwhelming, with a real desire to design something that's going to not only provide high quality asthma care for children, but do it in a sustainable way. They said they wanted a structured approach with all the information they needed to manage that child there at their fingertips and resources tailor-made for that child. So we then developed some working groups. We had a digital template group where we adapted Pdata for primary care. And then we designed 2 templates, a diagnosis template and a management template. Now these are digital templates that are embedded into GP IT systems and pull automatically the information about that child into the relevant sections. So when you go in, you automatically know when a child has had an asthma attack, how many they've had, how many SABA inhalers they've picked up, and how many preventers they've picked up. And you then work through the template, and depending on what the answers are, you then get different beat asthma resources depending on what they need. We then also worked on different patient pathways. So how is this going to work? Well, the digital triage tool will identify patients at higher risk of adverse asthma outcomes. And once identified, they are then offered an initial appointment at a diagnostic hub. And each primary care network will have 1 diagnostic hub. And this will be staffed by a practice nurse who's been trained for Beat Asthma Plus. They'll then work through the diagnosis template, including objective measures. And if it looks likely that they have asthma or confirms a diagnosis of asthma, they'll then go on to have a management assessment in that same sitting. This will be followed up over the next 12 months with ongoing reviews at their local GP surgery, again by local practice nurses who've been trained by Beat Asthma Plus. The project's going to start in January and will run for a year. So where else do we want to go? Well, building on what the young people told us about schools, and also inspired by Stanley Zeffler's work in Florida, we want to develop a pilot project for schools where we take asthma care directly to the children. We're also talking to clinical pharmacists, which is an area that I think is underutilised. Every child that picks up an inhaler has to go to the pharmacy to get it, and this is a really good opportunity to go through the basics of asthma management. So we wanted to talk about Beat Asthma. I hope you now know a little bit more about it, and maybe there's something in there that you think could be useful for you. You know about our training days, and if you want to have a training day in your area or even run one yourself, please let me know. And you know about the future directions for Beat Asthma. Beat Asthma has been hugely helpful in the Northeast, but it is being used in pockets across the country, and it may be that it would be better adapted for those areas by doing different things. So if there's things that could be done, please let me know. Similarly, if you want to join the team, that would be great, and you can help us grow it and develop it. Our vision is that there is one standardised approach across the country, so children are getting the same high quality asthma care, meeting all of NAD recommendations wherever they receive that care, be that in a healthcare setting, a pharmacy, or even a school, offering a truly integrated approach wherever they live. By working together, we really can improve outcomes, and maybe then we can prevent any further deaths like Tamara's. Thank you.
Dr. Townsend, that is such an impressive presentation on an extremely impressive invention. I'm sure a lot of people are really excited to know how they could get involved, and I know you said to contact you. Are there any particular challenges or opportunities that you've heard from people who've been trying to implement it in other regions that have differed significantly from your experience in the Northeast?
Well, I think one area in particular, so Birmingham got in touch and asked if we could translate everything into various different languages for their population, which we would love to do. And similarly, we were approached by somebody working in India saying, can we have a Beat Asthma India? And you know, we'd absolutely love to do that, but we did this with no funding at all. So we just can't do that at the moment, but we've got more and more people fundraising for us, and perhaps as it grows, that might be something that we would be able to do.
Brilliant. I mean, a follow-up question, how did you guys do it with no funding? That is just incredibly impressive.
The passion and determination by everybody involved was absolutely overwhelming. I think, you know, Tamara came from our region. She had been to a number of the hospitals in our region, and that's definitely struck a chord. It happened at the same time the NRAD report came out, but, you know, after Tamara's death, we had several more deaths in our region, and these are preventable deaths. So it didn't take hardly any persuading at any point to get people involved.
Thank you very much, Jan. Excellent talk, inspirational, and it's quite nice to see that you are stepping up and it's to keep on working to move into the future direction rather than showing the results and continuing what you are. And this is really inspirational. Well done. One of the questions from IAM is that Beat Asthma mentions about salbutamol weaning program. not sure whether you heard Mark's talk. He believes this is not logical and unsafe, and there is no evidence to support either of them to the weaning plan, and there is no research studies around. So what do you think the strategy should be?
So I did hear Mark. So I actually spent a year working in Vancouver, and they were absolutely horrified by what we did in the UK with the amount of salbutamol we used. And it was interesting working out there. You can see a totally different approach working well. So I kind of echo Mark's thoughts actually, that the symptoms are a flag to patients that they're not responding, and maybe we should go and get some more help. So the purpose of Pdata was to take the guidelines that have already been developed, but get them out there to the people that need to use them. But if those guidelines change, then we would certainly change ours too.
Brilliant. Thank you. Kirsten, do you want to?
Just aware that we don't have much more time for questions, but several people on the chat are saying that they would absolutely love to get in touch with you, and missed the email that you were asking people to contact you on. So I don't know whether we can maybe send that round on the mailing list, or actually if you pop it on the chat, if you were happy to do that.
Yeah, I'll do that just now.
Yeah, and just the last one for you, and this is from Priya, and so you're doing a huge amount of work, which is inspirational, and it's quite impressive, and there's no doubt has shown the work. And why does not Asthma UK fund such projects in the country where there's a huge amount of goodwill and motivation is there?
So I did approach Asthma UK, and it didn't go so well, if I'm honest. So yeah, okay. Good question.
Thank you.
Thank you.
Thank you very much, Jen, for the excellent talk. And there are lots of comments in the Q&A talking about your impressive achievements. So moving on to the last talk of the day, talking about complex asthma and the safeguarding. The prevalence of safeguarding has significantly increased in patients with asthma or problematic asthma in the last 10 years or so. And increasingly time we are spending in the MDT meetings about these children with the complex asthma. Pippa Hall is a senior asthma nurse specialist at Brompton Hospital. And she will be presenting few cases to illustrate her experience with safeguarding in children with asthma, particularly problematic severe asthma. Mrs. Pippa Hall.
Hi, I'm just trying to share my screen. Can you see that?
Yep. Yep,
Okay.
that's absolutely fine.
Lovely. Okay. So thank you, Atul, for that introduction, and thank you for asking me to come and speak today. As Atul said, I'm a clinical nurse specialist working at Royal Brompton Hospital in London. Safeguarding takes a big part of our time, and today I'm going to share a few key points from our experience. So a bit of background. Oh, is that moved along, that slide? I'm sorry.
Yep.
Is that fine? Okay, sorry. So the aims of this presentation today is I'm going to give a little bit of a background just into the work that we do, and then look at a recent safeguarding audit that we did a few years ago, which just highlights the amount of safeguarding work which comes our way. I'm going to share a bit of information about how we go about identifying safeguarding issues, and then in light of COVID-19, the extra challenges that has brought. Then I'm going to go through two very typical case studies that we see at our hospital, and then end with some challenges and summary to the talk. So a bit of background. We have approximately 60 children a year referred to our service for assessment of problematic asthma. And the aim of this assessment is primarily to determine which children have contributing remedial factors, which, if identified, can prevent more invasive investigations, unnecessary escalation of treatment, prevent hospital admissions, and ultimately improve our patients' quality of life. And I'm sure lots of you are very aware of our protocol. However, increasing amounts of time is being spent safeguarding children, including lots of time being spent in our multidisciplinary team meetings, discussing amongst the our MDT involves nurses, doctors, psychologists, physios, our in-house safeguarding team, the pharmacists. We do seem to spend a lot of time, anyone who spent time at our hospital will know that we spend a lot of time talking about our patients from a safeguarding perspective. We spend a lot of time liaising with social workers, schools and other professionals, completing referrals to children's social care or even to our in-house safeguarding team for advice and support. We help with coordinating and attending professionals meetings, the very time-consuming task of completing chronologies when we're concerned about patients, and then also coordinating admissions for observations, which I will go a little bit more to talk about later in this talk. So going back to the audit, a few years ago, we looked at 316 children who'd undergone an assessment for asthma with us, and we categorised reasons for safeguarding into both FII, fabricated induced illness, and neglect. And the risk factors we'd used for neglect were those patients where we were concerned about poor engagement with professionals, those ongoing poor adherence despite lots of intervention from MDT, poor symptom perception, or if there were concerns about symptom over-reporting, there might have been ongoing smoke exposure despite lots of help and advice to minimise smoke exposure, obesity, and poor school attendance. And then children where we were worried about FII were those ones where we felt asthma symptoms of a severity didn't necessarily fit with the objective measures. There might have been different hospitals and professionals involved with the same family. The story didn't fit with what the school or other professionals were reporting. And then we were also concerned if there was a reluctance to attend for more specialist tests and admissions, despite lots of reports of their child being unwell. And then also if our children were having poor school attendance or were being homeschooled when we couldn't really understand why. And obviously all of these things aren't taken in isolation, it's looking at the bigger picture. So the results of the audit, which as you can see on this slide, were children referred between 2005 and 2015. We identified 36 children out of the 316 where we had safeguarding concerns. 13 of those we felt we had concerns about fabricated illness and 23 neglect. And ultimately that resulted in 25 of our children being referred to children's social care during that time period. And then that resulted in 7 child protection orders. And then just going on a little bit on from there, you can see on this slide, but every year the blue bars are the amount of children that we picked up where we've had safeguarding concerns. And then on the red bar, it's the amount of children that we've actually made referrals to children's social services. So you can see that year on year, it's getting higher and higher, which I suspect is more a reflection on our increasing awareness. So how do we go about identifying safeguarding issues? Well, all children who are referred to us for difficult asthma undergo a comprehensive nurse-led assessment. This includes a home school visit, an adherence check, and we check adherence by looking at prescription uptakes from a GP, smart inhaler monitoring, and then we also have the luxury of being able to check for medication availability, correct inhalers, devices, etc. when we go and visit the home. It's also useful to know at this point if the family is already known to children's social care, and also whether or not the child's receiving disability living allowance or they're getting mobility allowance. This is quite often helpful to know whether or not the family might be getting some financial support for their child having asthma. We also look at smoke exposure by testing for urinary cotinine, which tells us if there's passive or active smoking. And of course, when we go and do the home visit, we get an indication of whether or not there might be smoking in the home. And then contacting the school. So we routinely contact the school of all our patients to check things like attendance, check they've got management plans in place, check the teachers and the school know how to deal with an asthma attack. But often while we're talking to the school, it's interesting to get information about how the child is, do they do sport, are they happy at school, and really does the story fit? You know, it's not unusual to have a parent coming to clinic telling us that their child is really unwell, symptomatic, can't even walk up 1 flight of steps to bed at night. They get so wheezy. And then when we speak to the school, we find out they're running around. The school sees minimal asthma symptoms. So it just helps us build up a bit of a picture of what's really might be going on. And we have lots of cases where we end up having a little bit of a perplexing solution. We might have ongoing symptom reporting despite no obvious remedial factors being identified. So everything might be fine, but yet the parents are still reporting lots and lots of symptoms. Or their investigations might be normal, and again, lots of symptoms. Or there might be ongoing concerns around adherence despite lots of interventions. Maybe we would have set up directly observed therapy, given smart inhalers, suggested lots of ways to improve adherence, but adherence is still poor. That would make us question why things weren't getting any better. We would worry about families where there is poor engagement with the multidisciplinary team as well. You know, often we will refer to psychologists or the physios if there's concerns about anxiety or dysfunctional breathing, and if parents don't engage or the family doesn't engage, that would concern us. Concerns over or under perception of symptoms would worry us. So when we get situations like this, after a long MDT discussion, it's very much a team approach here, we might consider bringing in a patient for a 2-week observational admission. So the admission usually lasts for 2 weeks. We always explain to the family why we want to bring the child in. It's usually to say that we've got a bit stuck, we don't know where to go from here, there's lots of symptoms, the child's still unwell, but we really don't know what's going on. So when the child arrives, we do baseline observations, check phenospirometry, urinary creatinine, blood levels for cortisol and prednisolone if they are on daily prednisolone. It's really important to try and get this done within a few hours, at least in the same day that they arrive, because things really do start to normalize quite quickly from our experience. We also do baseline asthma control tests, quality of life questionnaires at the start and at the end of the admission. Throughout the entire admission, all their medication is directly observed, and we also remove all their bronchodilators and advise the family that if the child becomes wheezy or unwell and they want their salbutamol, they need to be reviewed by one of the ward team to just check for some objective evidence. We very, very rarely have needed to give salbutamol for any of our patients who've come in for a 2-week admission. Then, as the admission goes on, we'll do regular spirometry and exhaled nitric oxide testing. Really importantly is psychology and physiotherapy assessments at the beginning and then with ongoing input throughout the 2-week admission. We also try as a CNS team to review these patients daily, and it's harder now since COVID, but pre-COVID we would make a real effort to take these patients out 2 or 3 times a week, take them to the park, take them out to the local museums, just to get them out and about as much as possible. What we don't want is patients lying on a hospital bed for 2 weeks, because that's not really the real world. And parents will sort of comment at the end that the child's been well, no symptoms, because they haven't really done anything. Obviously, children can carry on attending a hospital school, and actually when we're liaising with their normal schools, we advise that if they're attending hospital school, they can be put down as educated off-site, so it shouldn't affect their attendance. Then towards the end of the admission, we usually will feel the need to either arrange a professionals meeting, a team around the family meeting, or sometimes if we've still got safeguarding concerns, we'll make a referral directly to children's social care. So since COVID-19 kicked in back in March, it's presented a few more challenges for safeguarding. We all know that school is a protective factor, and back on the 18th of March, when the schools were all closed, we quickly had to identify which of our patients we felt would be extra vulnerable because they weren't going to school. Many of our patients are receiving their therapy at school. So again, we wanted to identify the patients who were not only on known to safeguarding, but also are having directly observed therapy. And as a team of CNSs, we set up a way of contacting these patients regularly, encouraging them to make sure that they take their inhalers regularly and just being a bit of a contact with them because we knew that they weren't going to school. Obviously, with limited face-to-face consultations, we've been mindful that some of our more vulnerable patients we haven't necessarily been seen, and I'm sure that safeguarding, problems with safeguarding might well be increasing because of this, and we're still slightly in that situation at the moment, although we are getting far more used to using virtual consultations. And as Andy Bush said earlier, I think there's no way that we're going to be going back to bringing everyone in all of the time. Obviously, limitations with DOT, directly as a therapy, which I've talked about, but we have been lucky enough to have access to smart inhalers. So patients have been, and we have for other patients been worried about, we can be monitoring their adherence remotely. And then all the usual meetings, professionals meetings, child in need meetings, and even just our in-house MDTs have invariably transferred to MS teams. And you know, I think we've all got used to it now, but especially a few months ago, it was quite a big change, and perhaps they probably weren't quite as useful as when we were able to do them face to face. So I'm now just going to go through 2 case studies. They're based on patients that we've seen at Royal Brompton over the last few years. So the first case study was an 11-year-old boy who was referred to us for difficult asthma assessment from a local hospital, with a history of poor lung function, usually below 50%. Although he attended routine clinic appointments, he wasn't brought to several stage 1 appointments, and mother was very difficult to track down right from the start. However, the opportunity was taken to complete a stage 1 assessment at a routine clinic appointment. And when we first met him, he had really high levels of BDR. His FeNO was 100 and his FEV1 was about 40%. He had a poor prescription uptake, and mother reported being depressed, anxious, and that their family had also been known to social services because mother had been in a violent relationship previously. Right from the word go, mother made excuses about not wanting a home visit, giving lots of various reasons as to why the home visit couldn't go ahead. One of the main reasons was that she was too busy at work to take any time off. So as we would do routinely, we contacted the school, and one of the first things the school said to me when I spoke to the welfare officer was, oh, well, yeah, no, mother's not very caring. We have real struggles getting mum to bring in this child's inhalers to school. They were also worried that this child and his younger sibling came to school hungry. And they did have safeguarding concerns, and they sort of discussed their concerns amongst themselves, but felt that there wasn't really any threshold for children's social care. Social care did confirm that the family was previously known to for domestic violence. We as a team, along with liaising with the school as well, made a referral to children's social care, and social workers ascertained that mother was about to be evicted from her home. His family were about to become homeless. Mother wasn't seeking appropriate help about getting new accommodation. But basically the outcome of this referral was that the social worker informed mum that in future she must engage with medical professionals and the case closed. He continued, however, over the next year or so to have really poor asthma control, and we felt that we weren't getting anywhere. So we arranged to do a 2-week admission. He arrived with very low lung function, as we would have expected, high FeNO and significant BDR, as he always did. However, his asthma symptoms improved significantly over the 2-week period. They pretty much normalised by the time he went home. Mum, bearing in mind he was only 11, visited twice throughout the entire 2-week admission. She said she couldn't get any time off work. Ward and hospital staff raised concerns about his behaviour, felt that he was a carer for his mother and younger sibling, and that he did all the cooking, and he did often report that he was worried about his sister at home. He was seen by psychology, and towards the end of the admission, myself and one of the consultants sat down and advised and chatted to mum that we had, concerns that her son had become basically completely well during the hospital admission because he was given his treatment, and that we were also concerned about her lack of engagement and not coming to visit. 2 days later, we discharged him, and mum didn't even come and pick him up. He was collected by his grandmother at the end of admission to be taken home. We planned to do a home visit a week later to check for any deterioration and any increases in asthma symptoms, and arranged for him to have all his therapy at school. The home visit was then cancelled by mother on 2 or 3 occasions. We eventually managed to get in and do a home visit, and I went myself with a psychologist who had worked with him on the ward as well. We both reflected afterwards that mother had prioritised virtually the entire visit on her needs, and the fact that she didn't enjoy her job, she was a single mom, she found it difficult because she didn't have a social life. And actually, quite ironically, during the visit, the school called mum. She took a call on her mobile, and the school said that her son was really suffering from his allergies, and he'd said that he hadn't taken his histamine that morning, and could mum come in and bring a tablet. We later found out that mother didn't go into school or bring the tablet. Despite advice from our psychologist, mother still hadn't sought any help for her anxiety and depression from a GP. Not long after this, however, the family were evicted from their home and they moved in with their grandparents. We were still very concerned, so we made another referral to Children's Social Care, actually explaining that we felt that this child was at risk of death. His asthma was so severe. So again, his lung function now dropped back to sort of 40%. The social worker wasn't able to engage with mother. However, because he was now living with the grandparents, and around about this time, the grandparents started to become more and more involved in his care, the social worker felt the case didn't meet threshold for child protection. And actually, since living with his grandparents, things have improved significantly. He's also grown up a few years now and he's taking a little bit more responsibility for his own treatment, and things are on the whole a little bit better. He's still receiving directly observed therapy at school, and we have a really good relationship with the school. The school probably phone us every 6 weeks to give us a little bit of an update, or if they have any concerns about him, they will give us a call. So we feel that he's safe now. Then the second case study I want to talk about today is a 9-year-old boy called John. He was referred to us with a history of recurrent A&E presentations, lots of admissions, and lots of courses of steroids. There's also reports of lots of allergy symptoms. He was on Seretide, Montelukast, cetirizine, and salbutamol. He'd previously been investigated at another hospital, but family were keen for a second opinion. So when he first came to see us, his spirometry pheno was absolutely normal. He was also non-atopic, looking at skin prick tests and specific IgEs. His school attendance was poor, less than 40%. Mum described really poor exercise tolerance, lots of nighttime symptoms. She described inspiratory wheeze and lots of anxiety around John. And actually, John's PIED, which is a Pediatric Index of Emotional Distress, scored him 15, which was quite high. His inhaler uptake prescription checks were all fine, however. So we did a home and school visit, and he lived with his aunt, mother, and older siblings in a 3-bedroom house. There were dogs in the home, and Mum informed us that she was on the housing list. She was really trying to find a new house to live in. Mother described multiple health issues for herself, aunt, and the siblings. And she asked us if we could write a letter to support rehousing, as dogs were triggering John's symptoms. Family were also receiving disability living allowance and mobility allowance. The school had concerns about poor attendance, but also told us there was a very similar pattern with the older siblings. They reported that on the days he did come into school, there were no symptoms of asthma, and he wasn't doing PE at mother's request. So despite mother reporting lots of concerns about high levels of anxiety with John, she didn't engage with psychology, and she also didn't engage with breathing exercises, despite several attempts from both the physiotherapist and the psychologist over a matter of about 12 months. Around not long after the home visit, Mum decided to take him out of school completely and commenced homeschooling. Despite this, there was no objective evidence for asthma in his regular outpatient appointments. However, Mum was still taking him to A&E regularly and was reporting regularly to us on the telephone that his peak flows were dropping worryingly low at home. What was also noticed was that John was often very tearful when questioned directly about his symptoms, and he often refused to even do spirometry, or if he did, put suboptimal effort in. And then, as time went by, we had a family member contact us stating that they had concerns. They felt that John was always well at weekends when they went to visit, and were a bit concerned because they knew that mother was reporting that he was really unwell and that he couldn't go to school. There were also several different health professionals involved by this stage. So we got him in for admission, and he stayed he was well when he arrived, and there was no evidence of asthma throughout the 2-week admission. He had a suboptimal exercise test because he didn't engage. After about 2 minutes of being on the treadmill, he got upset and said he didn't want to carry on. Mother continued to disclose lots more health issues for herself, including in front of John, that she was being investigated for cancer. We think these are unfounded. She also reported food allergies, particularly to milk, and gave some stories about how when he'd had milk, he'd become really quite unwell. However, he was noted to be taking dairy products from a ward with no issues at all. And then also during the admission, we were liaising with the local team, and they were a bit concerned because they had noticed on the charity request form for a holiday grant that mother had stated that this child had been prescribed Xolair. And they wanted clarification because they didn't realise he was on Xolair, and we obviously said that he wasn't. At the end of the admission, Mum was informed that there was no evidence for asthma and he shouldn't be homeschooled on the grounds of health issues. We felt that he was well enough to go to school. So post the admission, a professionals meeting was arranged. Chronologies from the local team, GP and us highlighted even further concerns. Interestingly, an anonymous referral was made to children's social care, not from health, but the local FII lead got involved. A strategy meeting took place, and the final outcome was that this child is now on a child protection plan. He was discharged from tertiary care as there was no evidence from asthma, and he's still on that child protection plan now. So, you know, these two case studies do highlight the sort of challenges that we have all the time, particularly around FII referrals. The outcome of these referrals can vary enormously, and I think it's primarily down to children's social care and social workers being unfamiliar with the concepts. Often we find different professionals can sometimes vary in their opinion around FII. And it can obviously have, not just for FII, but when we're making referrals for neglect as well, a negative impact on care provider, us at the hospital, and our relationship with the parents. We do quite often, if we're making a referral for neglect or concerns around the family, you know, try and work with the family as much as possible and explain that we might be making a referral because we feel that the family could do with a little bit of help and support. It goes without saying, I guess, that we get a few complaints every now and again, but throughout the whole process, it's really important to have clear documentation. So just to conclude, we feel it's important to always consider safeguarding in the assessment of children with severe asthma. The safeguarding team are key members of a multidisciplinary team. Increasing numbers of children with safeguarding concerns amongst our difficult asthma group of patients in line with increasing awareness. Increasing amount of time is being spent safeguarding our children. COVID has definitely increased the challenges in safeguarding. And finally, addressing safeguarding issues is a time-consuming but vital role in the management of our patients with difficult asthma. Thank you.
All, thank you so much for such a compelling talk about some really complex cases. We've got a few questions on the chat, and one of them in particular was around funding for the difficult asthma admissions and kind of finances, particularly asking about how much it costs to run one of these admissions and whether you have any data around the cost savings, obviously, although that's obviously a very difficult thing to measure in terms of quality of life and all those other things.
Yeah, I will be honest and say I don't know how much it costs, but I suspect it would cost a bit of money. I'm really mindful that it's always a scramble for beds. It's easy, but we don't do this very often. We probably have about 20 patients a year, but we really feel that a 2-week hospital admission can save a lot of time and effort down the line. And yes, we are really relying on the goodwill of the board to allow us to bring our patients in and do this.
And just a supplementary question to that, some teams are saying that they would struggle to accommodate a 2-week admission. Whether you think that there would be significant benefit just from a 1-week admission?
Yeah, definitely. And I mean, our sort of standard is 2 weeks, but absolutely. Sometimes we discharge people after 3 or 4 days if we get the information we need. We absolutely don't keep them in just for the sake of it. We usually say 2 weeks just to manage expectations in case we need that 2 weeks. But no, sometimes just 3 or 4 days is fine. So yes, absolutely. I don't think it needs to be absolutely 14 days on the dot.
Thank you, Pippa. Excellent talk. I think this is the issue we do see sometime, and it comes into discussion. So in relation to contacting school, do you seek consent beforehand, or do you contact based on the safeguarding concerns
No.
where consent is not listed?
Okay, so as part of our difficult asthma protocol, we contact schools routinely for every patient, not just for the safeguarding. And yes, we do tell parents when we're doing the assessment that we are going to contact the school, and we usually ask the parents the name of the school. I don't think there's been any instances where we haven't told a parent first. There have been times when parents have not been willing to share the school information with us, but invariably, as you can imagine, that's highlighted concerns in itself. If they don't want to share, give us details, or they tell us not to call the school. We do sometimes have parents who then get quite defensive and will say, oh, the teachers really don't like us. They're probably going to tell you a whole load of rubbish about us. The teachers are always having a go at us for not sending their kids in, sending my child in. They don't understand how bad the asthma is. So you kind of get a feel that there's a bit of a sticky relationship between the school and the family. And parents sometimes sort of pre-warn you. But again, when we as a team phone up the school, it's very interesting to get their perception. But for 90% of the time we phone up, it's purely just to phone up, check there's a management plan in place, check that they know how to manage the child's asthma. And then, as I said in the talk, sometimes we might already have safeguarding concerns before we the school. What normally happens is we chat to the school, get all the sort of standard stuff out of the way, like the management plans and the have they got inhalers in school? Do they want any support? And then often towards the end of the conversation, I might ask if there's anything else that might be useful for us to know in us assessing the asthma. And that's when it sometimes might come up. Or sometimes I might just say, routinely, it's one of our standard questions, do you have any safeguarding concerns about this family? More often than not, it's no, but obviously, as I've said in this talk, for about 10% of our patients, there might be not necessarily safeguarding, but concerns, especially around, say, attendance.
Thank you. Sorry, Kirsten.
Sorry, Atul. So we've got a question from Beryl Adler. So you were talking about the difficulty sometimes with social care understanding an FII referral, but actually also at times teams come across difficulties with social workers understanding the severity of a possible asthma diagnosis. Particularly today, we've discussed a lot about the fact that asthma still kills children. Does your team have any particular expertise about kind of communicating that message to social workers?
No, we really struggle as well sometimes. The classic example with FII is when we say we're really worried about this patient. We explain that we put on a referral concerns, and the social worker will come back and say, oh, I've been and done a home check and mother's shown me all these letters. Don't worry, it's fine. We're under all these different doctors. I'm sure they're fine. Don't worry, and it's like, no, that's the point. And then the other thing is, they're under the Brompton Hospital. It's a bit of a side fact of this question, but we do find that children referred to a tertiary referral centre, suddenly they turn up at an A&E, and the local A&E hears that they're being investigated at Brompton for severe asthma. Treatments get escalated because of that. And actually, my first case study, the social worker, the 11-year-old boy, and we really were concerned that he could die of his asthma. And when the social worker closed the case and said, oh, I've just told mum that from now on she's got to engage with the health professionals, she continued to not engage with the health professionals. So when we tried to make a re-referral, she said, no, I've done my assessment, and if mum doesn't engage, she wasn't being that helpful. And I said, look, this child is seriously at a risk of death if this mother, we're really seriously concerned. And the social worker actually told me that if that was the case, I really should be phoning the police and not her. She just really she didn't understand. I felt, so no, we do have difficulties for sure. And we have a great safeguarding team here who do support us with all of this. So sometimes they make contact with children's social care, sometimes it's us as the CNSs. But yes, we do have huge amounts of difficulty.
Yeah, no, we have had significant amount as well, where there's a huge amount of evidence as a respiratory pediatrician, where people are not taking the treatment, frequent asthma attacks, and it's very difficult for them to understand, I suspect. They are more used to patients with when there is subarachnoid hemorrhage or shaky baby syndrome. So I think where the evidence is very clear in black and white that this is abuse and needs to be done, where there is indirect evidence of it, or especially with disease like asthma, where you can have a normal lung function one day and after 3 days you can die from it. It's quite difficult. Brilliant. Thank you very much, Pippa. I think there are still some questions, but it's 5 o'clock, so I probably finish on time. But thank you very much for the excellent insight over it. And it's, yeah, it is fantastic.
Thank you. Well, thank you for asking me. It's been a fantastic day. It's been really lots of really good talks.
Thank you, Pippa. Thank you. So I think we probably close the masterclass now, and I really want to thank everybody for an excellent day. I thoroughly enjoyed it. We had over 1,000 people registered, so I probably haven't seen the data how many have attended, but the attendance throughout has been very high, and on some occasions has been over 600 people who were live during the sessions. Those people who have registered will get the certificate emailed to them in the next few days. I would be grateful for your feedback, and then because that will help us decide in what we do with the other master classes we have, and the 4 or 5 master classes we did, which we haven't yet decided how we need to take them forward. I'm grateful for the team, and there was a big team of about 15 or 20 people who we were meeting regularly for the meeting in April, and setting it up. So grateful for the team who's put all the effort together, and because the pandemic needs to be postponed, I really want to thank the co-chairs who helped me screening the questions, Adam, Alison, and Kirsten. Thank you very much. Twitter moderators, again, Adam, Louis, and Sab, really